On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers, Dr. Robert Fineberg and Sasha Thompson. Dr. Robert Fineberg is board certified in family medicine. He earned his medical degree from the University of Colorado School of Medicine in Aurora, Colorado. Dr. Fineberg completed his residency as a family medicine physician and hospitalist at St. Anthony's Family Medicine in Westminster, where he was chief resident. There, his training included primary care, integrative medicine, psychiatric care, obesity medicine, hospital medicine, and obstetrics. Dr. Fineberg further obtained his diplomate of the American Board of Obesity Medicine. Dr. Fineberg passionately encourages his patients to live their best and healthiest lives and has a specific interest in helping patients to improve their mental health and achieve their weight loss goals. He sees patients at Boulder Creek Family Medicine in Boulder. Sasha Thompson holds a Bachelor of Arts in Spanish and Global Health from Vanderbilt University and a Bachelor and Master of Science in Nursing from Emory University. She completed the Nurse Practitioner Residency Program through MedLink, Georgia and Emory University in 2021, and then earned a postgraduate certificate in endocrinology from Duke University. Sasha has a special interest in weight loss medicine and works closely with patients as part of the weight management program. She enjoys partnering with individuals and families to understand their unique health philosophies and goals, creating care plans that are personalized and effective. She sees patients at Northwest Family Medicine in Superior. Welcome to our speakers tonight.
Thanks, Karen. Hey, my name is Rob Fineberg. I am a physician at Boulder Creek Family Medicine, and I have a specialty in obesity and weight loss medicine. So this evening, we're going to be talking about, why we do what we do, which is evidence-based, compassionate weight management care. Tonight, we're going to discuss how we treat obesity, and we're going to offer some guidance, some tips on each of those aspects, and then some next steps on how you might engage with us in our clinics. Okay. We're also going to talk about what obesity is as a condition and what it is not. We'll talk about how we approach our care, and we'll offer some tools and support that would be available to you at our clinics and within the Boulder community organization. And at the end, we'll have some time for some questions, more specifically to what you're looking for. Okay, so let's talk about obesity. So obesity is more than just a weight condition. It's a chronic, complex condition that involves multiple aspects. One, it being genetics. There are certain genetic drivers that lead to different hormone levels in our bodies that make us more predisposed to wanting to eat more, and these are evolutionary drivers that have kept us alive as a species, and in an environment of plenty, it can sometimes lead to excess weight. Other contributors, like I mentioned, are our hormones. So there are multiple hormones that can drive our hunger and our weight management. Those include hormones such as ghrelin, which is just known as the hunger hormone, leptin, which is the satiety hormone, insulin, which is a hormone that helps us store away energy and regulate our blood sugar, and cortisol, which I'm sure a lot of people have heard of, which is another hormone, which is a stress hormone, which sometimes is good for our energy management, but when it's chronically elevated can sometimes dysregulate our hunger and some of those other hormones as well. And then, there are certain behaviors, the way that we eat, and the way that we move, the way that we sleep, that can drive our weight, can drive our hunger, can drive things like that. And then there's the environment that that we live in, that we've grown up in, that can drive some obesity, right? So again, we evolved as a species, not with a 7-Eleven on the corner, and now that we have access to very hyper-palatable foods, sometimes just the access to those foods can drive us there. And then there are places like food deserts where there are not fresh food, fresh fruits and vegetables available, for us to bring home and cook, and so we are forced into things like, highly processed foods and fast food. This is not necessarily a matter of willpower. There's a lot of people who will get down on themselves because they are trying, but they're always driven to eat more than they think they should, or other foods that maybe they shouldn't be eating. But it's a lot more complex than that, and I kind of invite our audience to give yourself a break on this one if you've been struggling with it. There's a lot that contributes to this condition. And something that's important about overweight and obesity is that this is not just a matter about what's going on kind of around your stomach, but it really does impact almost, if not every organ system in our body. There's the fat pad around the heart, which can increase cardiovascular disease. There's the pressure on the chest, which can create something called hypoventilation syndrome, or there's sleep apnea. It can affect our sex hormones, testosterone, estrogen. It can affect our vision, our skin. I mean, there really is almost no system that obesity doesn't touch, and that's why it's important for us to really address it. And so why does it matter? So like I mentioned, so it is tied to multiple chronic diseases such as diabetes, heart disease, increases risk of multiple cancers, can lead to arthritis due to increased weight on joints. Certainly interferes with mental health disorders as well. And there's a lot more that obesity can affect. And reducing weight, even as little as 5 to 10 pounds, or even 5 to 10%, can dramatically reduce risks associated with things like hypertension, diabetes, and other diseases. And the evidence shows that early interventions that can actually improve outcomes. So not waiting too long, and if we can arrest weight gain early on, it can improve long-term health. So how big of a problem is this? Well, it's a no pun intended, a huge problem. Over 40% of US adults have obesity, and almost 10% have severe obesity, which is classified as class 3 or greater than 40% adiposity. And unfortunately, it's only going up, and that's across all age patterns, under 20 to over 65. And sadly, this is not just affecting adults, but this is also affecting children. And we do see children in our clinic. Over 20% of the kids in the U.S. have obesity, and that is a tragedy. And a lot of that is tied to both food, screens, a lot of behaviors, things like that. And it is something that I think we can address, and we can address early on, so that this does not become a lifelong issue. And I mentioned over 20% have obesity. 7% have severe obesity. Again, that's greater than 90. I think it's greater than 120% of the 95th percentile of weight. And like I said, if we can address this early, we can reduce the risk of chronic disease. And here is a slide that kind of just shows how that trend has been increasing. So if you look back in the early 1960s, less than 15% suffered from obesity, and severe obesity was just a tiny little tick. Where we look in between 2017 and 2018, we're well past 40% who have severe obesity, and around 10% that have severe. Let's see what else. And it's, while it's a tragedy for each individual that suffers from overweight and obesity, there is also an economic burden that should not be ignored. Over $170 billion in annual medical costs just associated with the diseases that are comorbid with obesity. And then there's the productivity losses. There's the out of work for orthopedic issues, for doctor's appointments, treating these chronic diseases, somewhere between $3 and $6 billion a year, which is a staggering number. And that affects not only medical costs and productivity losses, but the insurance and healthcare systems as well. So I'm going to invite Sasha up, and she's going to talk to you about our approach on how we address our patients who have overweight and obesity, or who are trying to arrest the increase in weight before they get there. Thank you.
All right. Thank you, Dr. Fineberg. And thank you, everyone, for having us. I'm Sasha Thompson. I'm a nurse practitioner with Northwest Family Medicine. So I'll just jump right in. So I'll start by telling you a little bit about what we do as a team, because this is really a team approach. We start by getting to know you as the patient at the very first visit. This is a 60-minute visit, so it is sometimes longer than most people have seen their primary care. And we do that because it does matter to us to understand each individual's goals, their prior history, and kind of where we need to start intervening to help kind of progress along that pattern. We don't have any specific weight loss philosophy, just science. We don't put you on specific diets, no specific exercise programs. Our main goal is to create a plan that works for you long-term and can evolve long-term with you, hopefully as you progress on your journey and maybe don't need us anymore one day. As we approach weight management in general with science, we also use our experience as clinicians. We look into lab results that might be something that's contributing to weight gain. We can refer to dietitians for support. They're really helpful with our meal planning and supporting you in between visits. And we can also refer to a network of specialists that we have to manage comorbid conditions like sleep apnea if we find something along our getting to know you process. Let's see. So really what our goal is to treat obesity for what it is, and that is a multifactorial condition. There usually isn't just one thing that has led people to our office or led you to where you are today. So that's how we address it. We address all of the contributing factors: biological, behavioral, emotional, social. And really our goal is to look at the long-term health picture, not just your specific short-term number changes. Those are really exciting to celebrate, but they're not kind of the big picture that we want to be able to give you in terms of comprehensive care. So what we don't do is we don't shame or blame. There is no space for that in what we do. We're here to support where you are. And we're also here if maybe some of those thoughts of shame or blame are there to help you work through those. We do have access to counseling and also hope to create that supportive environment just within our offices as well. Again, we don't support extreme diets or extreme rapid weight loss programs. Those generally do lead to regain of weight. And a lot of people have tried those before and they haven't worked out long term. So our goal is not to do that. We don't support, boot camp type exercises. Really, our goal is to find what works for you. This is not a one size fits all process. While there's some common things that help people with weight management, how they're applied to each individual is really important in terms of making sure that you're successful long term. So the major areas we focus on in terms of our weight management program and kind of where you would want to start in terms of your weight loss journey would be looking at what would be a sustainable nutrition and activity change for you. looking at where we can identify parts of your environment that may be contributing to weight gain or difficulty losing weight. We also focus on making those changes slowly over time so that you have time to adapt to changes in your schedule, changes in your routine. These are big things that you're kind of tackling with weight management, and we want to make sure that every step along the way, if there is kind of sticking points that come up, we can address those. We also want to focus on creating that stigma-free environment. That starts with how we talk about weight, and we make an effort to talk about it in a non-judgmental way. And if that's something that would be supportive to hear as a family, we can include the whole family as well. As far as kind of our main overarching focus, it's really to empower patients with the information they need to feel like they have control over their long-term health, which is probably the most common reason people present to the doctor anyway, and we're hoping to support that as well. So as far as nutrition goes, this is kind of a good place to start because a lot of weight loss happens here, and kind of our long-term success happens here. For maintenance of weight and kind of long-term recommendations, we can think about kind of three main pillars, shall we say. One is getting as much food as possible from the whole foods. So that's foods that you have to cut up. Some people think about it as the perimeter of the grocery store. But in general, getting as much of your nutrition from those big whole foods that we cook and engage with. And sometimes it can be a fun family activity when we do that. The other pillar would be getting and optimizing fiber and protein intake. The exact amounts are pretty individual depending on kind of your health status and other factors, but in general, what I usually recommend is starting with awareness of where you're at, starting to read food labels. That can be a particularly important point when kind of gaining an awareness of what your nutrition looks like. The other part is portion awareness. So we don't like to talk about portion control. This is a lifelong learning process. As your activity changes, portions change. As your needs change over time, portions change. So what we're hoping to help with is your awareness of the portions that you need in response to your activity and environment. Right. So things that are not helpful when we talk about nutrition is calorie obsession or extreme restriction, and really rigid meal plans. Again, this is probably something most people have tried before. A lot of kind of the more kind of fad diets focus on this. That's not our goal, and I can't encourage that. But if we focus on adding things to our daily life in terms of adding nutrition, adding fiber, adding protein, our brain generally responds really positively to adding rather than taking away. So I think that's a really good place to start on your journey. So what does this look like in your actual daily life? A really key part of this is not skipping meals. I know it can be super tempting to do that, especially kind of in the beginning of weight loss. The thought is kind of a restrictive type of thought. But when we think about weight management, and back to those hormones Dr. Fineberg talked about, our goal is to support nutrition throughout the day and regulate those hormones throughout the day. And by getting regular meals in, that's how we do that. So some people, that looks like having some meals with some snacks in between. Other people, that looks like splitting up their larger meals so that they don't have to prepare extra meals. Really, the goal is to never arrive at a meal hungry, so that you can make that appropriate portion decision for yourself, and also sustain those energy levels throughout the day. As far as getting enough protein and fiber, again, this is super individual, but when we think about reading food labels, a good place to start with protein and fiber is take what's already in your pantry, and as a family go through kind of the foods you commonly eat for dinner, if that's a meal you have together, and think about, how do I feel after I have a meal with some good amount of protein, or how do I feel after I get enough fiber throughout the day, and start making a note of that. That can be just noting that as a family or journaling. So those are just kind of some strategies to start with. As far as minimizing processed foods and getting nutrition from whole foods, really for weight loss, we're also trying to avoid getting too many of kind of your main nutrition or too much of your main nutrition from liquids and bars. Throughout the day, they can be a helpful tool, but certainly relying on them is not the long-term goal. I don't think anyone gets joy from a protein shake. So I would say using them as tools, and then also making sure you're getting enough of those whole foods. In terms of doing this, a helpful strategy is meal planning as a family. Sometimes that looks like meal planning on a Sunday. Sometimes that's like monthly meal planning, whatever works for you as a family. Really, we're just focused on building healthy habits. Both Dr. Fineberg and I have jobs, have families. We're not focused on perfection, just making sure you're progressing towards kind of longer term healthier habits. All right, so next piece of this is the movement piece. I think a really helpful place to start is recognizing that our bodies were literally made to move. In fact, our mental health and our physical health depend on it. So while our kind of modern lives place a lot of barriers in front of us sometimes, I think this is more of an opportunity to get creative in how you move your body and when you do. Kind of rather than avoiding physical activity, avoiding prioritizing your time, and avoiding putting this down on the priority list, because really it is a huge priority in terms of taking care of your health. So how do we do this? One is we do recommend starting movement or physical activity where you are, gradually, small and with kind of incremental changes in terms of increasing frequency or duration of the activity. Really, the goal is 1, prevent injury, 2, create a long-term plan that you can maintain even when you have some life changes that may kind of present as barriers. So when we think about where we want to start in terms of goals for activity, there's kind of 2 parts to this, I think, that we can think about. One is the aerobic activity. So we're thinking about biking, running, walking, the elliptical, swimming, aqua jogging, stair climbing, dancing, all the above, and doing about 150 minutes a week of that moderate to intense activity. Now, if you're starting from no outside activity, I would say 150 minutes is not kind of the immediate goal. So let's start with 1 to 2 weeks, 1 to 2 days per week, and kind of progress from there. But if you want to have kind of a big overarching goal, that's kind of where ultimately we want to be. A common question we get also is, how do I increase my metabolism? And this is where kind of the physical activity piece comes in. A really important piece of this is the strength training or resistance training. So when we increase muscle mass, the idea is we also are improving our metabolic rate. So the recommendations for resistance training can vary pretty widely depending on kind of where you're starting, what kind of orthopedic issues you may have. But a good place to start would be thinking about 1 to 2 times a week again, and finding an activity that you enjoy. The point for resistance training in terms of managing orthopedic conditions, in terms of preventing long-term injuries, is to start slow and increase gradually, just like aerobic activity. The type of exercises, again, depend on your specific situation, but a good place to start would be functional movements. So things like picking things up from the ground, pushing, pulling, reaching, leg lifts. So You can even start with chair exercises. Sometimes people prefer to start with light weights or just body weight. So all of those are really good places to start. And we have lots of resources if you need some direction on that. So last point I think would be, if you are having some orthopedic issues that you feel like are a barrier to you engaging in movement or engaging in movement pain-free, we can help coordinate your physical activity with a physical therapist, occupational therapist, physiatry. So lots of support available to you. And certainly physical activity actually can probably help long-term your orthopedic issues. So don't let that be a reason that you don't seek support, because there's lots available. So another big part of what we do on our kind of initial evaluation is evaluate your sleep. But a lot of patients are pretty aware of this themselves. The reason we do that is we're looking at poor sleep altering those hunger and satiety hormones, the leptin and ghrelin. And poor sleep also being related to weight gain is also related to increased insulin resistance. The kind of reason we screen for obstructive sleep apnea, or a common reason that people struggle with sleep, is that while it also increases that weight gain and insulin resistance, it also can increase your risk of heart attacks and strokes. So really, the whole reason we do this is for prevention. So that's a key part of it. When we do screen you for sleep issues, we'll ask about fatigue, snoring, and if you already have those issues, that's something you can talk to your primary care about, and we can help coordinate that as well. So just to kind of give you an idea of what obstructive sleep apnea is, and what we're talking about is the process by which people stop breathing during sleep, either due to anatomy or due to another type of obstruction related to weight. And it can lead to increased hunger. Usually when people have sleep apnea, pretty tired during the day, so you don't want to move as much. And also that insulin resistance. Ultimately, the signs you're looking for, just to kind of give you some places to start, would be loud snoring, people telling you that you stop breathing in your sleep, waking up gasping, headaches or dry mouth in the morning, and not feeling totally rested, even though you feel like a good night's sleep was what you had had. So how can we improve sleep if you don't have sleep apnea? In terms of sleep schedule, we try to maintain a regular schedule across the week, even if you work shift work, or your schedule during the week is different than your schedule on the weekend. Also with that would be a regular bedtime routine. This is often called sleep hygiene. Lots of recommendations on this, but a good kind of couple of things to start with would be avoiding eating or screen time too close to bedtime. Of course, not drinking caffeine too close to bedtime as well. And then making sure your sleep environment is cool, dark, putting work away from your sleep environment, making sure that is kind of the most restful, peaceful place for you. And again, if you're feeling like you're having trouble getting to sleep or staying asleep, that would be a really great appointment to have with your primary care, and we can also kind of initiate that conversation and get you coordinated with the right people. So the next kind of big part of this is kind of the mental health piece. In terms of weight management, we do screen for depression, anxiety, binge eating disorder. Sometimes other things come up while we're talking about kind of mood and how you're feeling in general, but those are kind of the big screeners that we do. And really those are kind of the big influences on how we choose food, how we're able to move, and how we sleep. So that's kind of our goal in identifying those, is to optimize your ability to be successful from a kind of holistic perspective. This is kind of an example of some of the questions we might ask you at the visit. So kind of big takeaways from this is, one, if this is something you're struggling with and you have a relationship with a primary care, definitely get in and talk with them. But if this is something you haven't talked to anyone about before, let us be the first people. We're happy to kind of start where you are and make sure you have the resources you need to address this completely. And we can also talk about medications that may help with weight loss, that may also help with mood, or adjust medicines that you may be using to help with mood that may be contributing to weight gain. So we'll talk about that in just a second. So as far as medicines for weight loss goes, which I think is a pretty big topic right now, when we think about how we prescribe these or how we might start these, really our big factors we're considering is what other conditions might you have as a patient. Insurance coverage, unfortunately, is a concern. How comfortable you are with medicines and your preferences around those. And we may also consider deprescribing or taking away some medicines that maybe aren't necessary anymore, or adjusting doses to make sure that you have kind of the optimal picture for your journey here. Oops. I think I skipped one. Oh, okay. So as far as medicine options, there's a whole landscape available to you. To give you an idea of what we might talk about, depending on your particular situation, we do have the GLP-1 medications for weight management. In our case, that's the semaglutide or Wegovy, and tirzepatide or Zepbound. We also may talk about oral options like metformin, a combination of bupropion or naltrexone, which may also be known as Contrave, phentermine, and topiramate. There's another medicine that is a combination called Qsymia. And really, these are just tools. The main kind of pillars of what we do is everything else we've already talked about. And these are kind of tools we add to your tool belt when we need them and when they're appropriate, and safe, of course. And really, our goal is to treat this as a holistic picture for you rather than just prescribing medication. So other things that we do in terms of looking at medications, and disclaimer, don't try to adjust medicines on your own. This is just information. If you need to adjust medicines based on this, definitely make an appointment with the provider that you see. But other medicines that we might look at as contributing to weight gain potentially are mood medicines, so a class called SSRIs, SNRIs, insulin, heart medications like beta blockers. So we may coordinate with your primary care or your cardiologist, endocrinologist, to make sure that those plans are optimized for you. And sometimes we even look at treating the other conditions that we talk about together with medicines that may also help with weight management. So a good example is using topiramate or Vyvanse for binge eating disorder, using naltrexone for an individual that may have a problem with alcohol or a problem decreasing alcohol. We may use bupropion or Wellbutrin for depression and anxiety. We may use topiramate for migraine management. And we may use the metformin or the GLP-1 medicines for insulin resistance and PCOS. Really, any of these might help with what's commonly called food noise. So that's kind of where we would start with treating other conditions. And we ultimately can start initiating the conversation about surgery with you if that's kind of what would be the best option or an appropriate option for you. To give you an idea of who might benefit from surgery options, it would be someone with a BMI greater than or equal to 40, or a BMI greater than or equal to 35, with other comorbidities, so other conditions like high blood sugar, high blood pressure, high cholesterol, and it can be a really effective tool for the right person. And there's a lot of really great data, especially in the realm of type 2 diabetes for surgery options. But really, our job is to initiate the conversation. And this does require kind of a lifelong commitment to follow up. So we can start talking about, whether that might be the right option for you or whether you want to try some other things first. So the kind of big picture of what we do and what long-term weight management is behavior change. And it's a skill like every other skill that we learn in our lifetime. It develops sometimes slowly over time, but there are things that we can do to help support that growth of that skill. One of those is goal setting. In terms of goal setting, I think kind of the intention when we're super motivated and we've made that appointment and we're ready to get started is we make a lot of goals all at once, and they can sometimes be super general, like eat better, or sometimes it's cook more at home. Those are awesome goals, but a really good way to help kind of tailor those goals to start with is make them achievable. So something not kind of high in the sky, but kind of super achievable, say in the next month or so. Make them measurable, so you can set specific time ranges, getting out for a walk for 30 minutes once a week, that kind of thing. But also make them meaningful to you. Making these changes is hard enough, and having a why behind why you're doing this can be super motivating and keep you kind of on the path that you'd like to be on. The other is we can also help kind of keep that motivation high and offer you some alternative perspectives on some goals that you might have had or felt like you hadn't reached. So that's kind of where we can help with this. And kind of the last part of this is we can also give you some tools to kind of monitor your progress in all of this. That can be journaling. We can use apps. I have patients that sometimes check in frequently with us. Really, whatever works for you is kind of the plan we make. And ultimately, our goal is that behavior change. So however we get there, we work together to figure that out. So to kind of reiterate a little bit of what Dr. Fineberg had said, the whole why behind why we manage kind of weight long-term, address obesity is that 5 to 10% weight loss generally improves blood sugar, blood pressure, cholesterol, sleep apnea, all super common things nowadays in primary care. And what we're hoping to kind of achieve with weight loss goals can be completely related to health goals, or it can be number goals, and we can do both. So I think don't let number goals be a barrier to you kind of progressing or setting goals. Sometimes setting a goal of long-term being able to decrease your blood pressure is a great place to start. So to give you kind of an idea of where you might want to start in forming your own goal, if you're super motivated after this talk, is start with one goal that you plan to try to achieve in the next month. Make it super specific, so starting walking 1 day a week at the park with my mom for 30 minutes, like super specific if you need to, and make sure that you have in mind kind of what you feel like is attainable and what would feel like success to you. We try to celebrate the other things other than numbers. So when you're achieving that goal, if that number on the scale doesn't go down, we can focus on things like improved energy, feeling more confident, feeling stronger, feeling more like your mood is better. Sometimes it's feeling like you're being a good example to your family. So all of those things can help motivate us when the numbers don't change as fast as we want them to. So ultimately, again, tracking wins, we're really looking at what's a win for you. Our goal is to meet your goals. So a good place to start might be journaling and being mindful of what is important to you. And that is kind of where we would start and where success would be tracked from. To give you an idea of kind of the number success that a lot of our patients have had, we've seen about 684 patients. about 6,794 pounds lost. And highest percentage would be 43%, and highest weight loss was 159 pounds. But again, numbers aren't everything, but if you are motivated by numbers, we have them. All right, as far as what we do now, if you're feeling on fire to get started, we're here to support you. We see adults and kids. In fact, we encourage the whole family to be involved. Generally, that results in better outcomes. We can start the referral process to specialists if that's kind of where we need to start. Really just bring your questions, bring your goals. We'll meet you where you are. And if there's kind of any big things to take away, any one of the pieces we talked about could be a whole talk in of itself, but really what we wanted to get across today is that obesity and weight issues are treatable, and there's no space for shame or blame in this process, and you're not alone. We've got a lot of people ready for support, and the conversation in society has been really exciting. But it also can be scary to start. So we just want you to know that you do deserve support when you're ready for it. And we hope to deliver that with science and really caring for the whole person. All right. So I will invite Dr. Fineberg up here and we'll answer some questions, I believe.
Thank you guys very much for your presentation tonight, and we want to remind our audience that now is the time for Q&A, so please put your general question in the chat box below the video and we'll get to as many as we can tonight. And in no particular order, we'll just start asking some questions. So, to what extent do you believe that technology drives obesity, particularly in young people?
That's a good question. I mean, any time that kids or even adults are distracted from going outside and moving their bodies, I think that's a tick on the column of obesity or non-movement health related diseases. So I'm not sure I could quantify that, but a non-insignificant amount for sure.
Okay. This person, since COVID, they've craved sugar. Any suggestions for how to remove sugar cravings?
So a good place to start actually would be that increasing protein intake and increasing fiber intake. That's a easy place to start, and also recognizing that those cravings are probably coming from a lot of different places, and making sure that you are supporting your energy throughout the day by getting the regular meals. A lot of people have those cravings late at night or in the afternoon, and sometimes that actually comes from restricting calories too early. So those are kind of some suggestions to start, but if you feel like you need more specific guidance, let us know.
And I guess the one thing I would add to that also is that COVID, the disease or not, has very much changed our society, where we've become a lot more homebound and been able to do a lot more from our home. A lot of people have hybrid lifestyles where they're working from home, very close to the pantry, where those sugary foods are, and then we've just kind of developed a taste for it. So, I mean, for sure, that has been a big influence on our diet.
Is fruit a good substitute then, or it depends on your weight loss goals?
I mean, absolutely. I mean, I would say that fruit is an excellent sweet alternative to a Snickers bar.
Okay. This person is overweight. They also have sleep apnea. Do you recommend Zepbound specifically?
So Zepbound is approved for sleep apnea, but it is pretty individual in terms of what we would recommend. So that would be a case where we would need to have an individual conversation.
Okay, so they need to come in. Okay. If someone wants to start this weight loss program, should they see Sasha or Dr. Fineberg, and does it matter?
I guess it would be whoever you're comfortable seeing. I've I've got a little bit of a wait list at this point. I've been doing this for a little while. So if the goal is to get in quickly, definitely Sasha. But she's also not a second tier either. I mean, she's excellent at what she does. It would be whoever you'd be more comfortable working with.
Just want to make sure you guys have the best fit.
Yeah.
Okay. What is physiatry? Am I saying that right?
Physiatry.
Physiatry. All right.
A physiatrist you can think about them as a non-surgical orthopedist. So a sports medicine physician is sometimes what they're called, but they try to do orthopedic interventions that do not involve surgery. I guess would be the best way to say that.
This person has always heard that it's better to have most of your daily caloric intake early in the day. Do you think this is true? And you did mention try to stop eating by sometime in the evening. Did you have a time frame for that?
Yeah, so that's mostly related to sleep issues. So having large meals close to bedtime, so like within the 2 to 3 hours before bedtime, can actually sometimes make it difficult for people to fall asleep or stay asleep. Also can cause a lot of issues like reflux that some people find bothersome when they sleep. But as far as I think this might be a question about like time period for eating. This is super individual based on your schedule, but there's no specific time that you have to stop eating if you're not having any issues with that causing sleep issues. It can be helpful to eat more during the day to help with those cravings that sometimes hit at night and when you're close to the pantry at home. But there's no specific time period that you have to stop eating. That answers the question, hopefully.
Okay. This person's A1C is 6.3, up a bit from 6.2. Several docs would prescribe metformin, even though the value is below 7.0. Do you think that exercise is probably more important in lowering A1C than diet?
That is a good question. Ultimately, I would say nutrition is going to be usually the culprit here. So probably the most effective way between nutrition and activity would be nutrition. Now, activity, is super important. I always tell my patients, I don't think there's 5 medications I could prescribe for them that would be as healthy as a regular exercise routine. So I would say that I wouldn't think of it as one or the other. A better or a more healthful nutrition plan and more activity together would help lower that A1C. Metformin is an excellent tool. Usually when people are pre-diabetic, they are also insulin resistant. And that insulin resistance can cause large fluctuations in hunger cues. So I think actually all 3 of those would be an excellent approach to that individual.
Regarding medications, any recommendation for how to deal with medications that increase appetite? Right now, just maintaining their weight and not gaining is taking quite a bit of effort.
Sure. Yeah, so I think a good place to start here is give yourself some grace, especially if this is a medicine that the benefits outweigh the risks of weight gain for. And also recognizing that again, some of this is not within your control, but on the same side, also recognizing that the same pillars of management for nutrition and activity can help with this. And if weight maintenance is the goal right now, great, let's embrace that. And also maybe let's adjust goals according to kind of what the benefits versus risk of that medication might be. So if you have something to add there.
Oh, that sounds great.
Okay. Following a long-term diet plan and significant weight loss, what do you recommend for losing the remaining weight from those resistant locations like the belly in a man? Would you recommend surgery?
I don't know. So, yeah, weight loss is complex, and certainly as you get kind of as you lose weight, it becomes harder, and it becomes harder to hold on to that weight loss. Part of the reason is one of the hormones that we talked about, leptin, which is that satiating hormone, is actually produced by fat cells. And so once you deplete those fat cells, those leptin levels really drop, and then so you're never or your satiating cues are really, really low, and so it really makes it hard to kind of keep on losing weight and then maintaining that weight loss. Sometimes the weight is just stubborn. I mean, and for different people, it gets placed in different places. So often we talk about central adiposity and the health risks associated with that. That could be a whole nother lecture. Some people hold it in their thighs, in their neck, their arms, and things like that. And there's no specific way to target different parts of the body. Fat loss is usually universal throughout the body. For instance, doing crunches will not get rid of belly fat. So it's really genetically predisposed about where you hold it. And I don't think that doing something like liposuction would never necessarily offer any health benefit.
Okay. That was a question for quite a few people, that they may get the weight off, but then they yo-yo afterwards. And especially as they age, they may yo-yo. And any comments on that and how to successfully maintain keeping the weight off without feeling hungry all the time? And having to put that much thought into it too was some of what people were asking.
This is kind of where that mental skill of behavior change, and really it's not just a mental skill, it's a kind of whole body skill, comes into play. With yo-yoing, again, it's probably a lot of things contributing, maybe some life events that were particularly stressful, surgeries, hospitalizations, all of that can kind of contribute to our changes in weight throughout our life. But a common kind of feature of when we are able to maintain weight is we make the kind of nutrition and activity changes a habit, and something that actively contributes to our sense of well-being throughout our life. And also making sure that those kind of goals and habits we set are flexible enough that as we age, we can alter them to meet kind of different needs. So if you were a runner at one point in your life, awesome, and running isn't possible forever sometimes. So adjusting kind of what activity looks like for you, and maybe this is an opportunity also to find joy in trying some new activities, looking into community for options for exercise. But as we age, I think kind of main thing is there are a lot of physiologic things or biological things that are contributing to weight gain, but there's also a lot of environmental things, and those are some things that we can control.
I guess the thing I would add to that is also, like Sasha mentioned a couple of times, is give yourself grace. No one's weight stays the same over time, and I think a lot of our patients suffer from perfectionism, and then when something doesn't go the way that they were expecting it to, life event, whatever, and then they gain a few pounds, they kind of throw their hands up and be like, oh, well, there's a couple pounds, so I might as well just stop doing this. And the thing that we encourage with our patients is give yourself the ability to have a bad day or make an unhealthy decision, as long as you get back on the horse. And generally, that is a really good defense against kind of like out of control kind of weight rebound.
Stroke alert activation, emergency room 4 now. Stroke alert activation, emergency room 4 now.
Okay. How to lose weight for people with PCOS?
Sure. So PCOS, polycystic ovarian syndrome, for people who don't know what that means, it's difficult. Usually because with PCOS comes insulin resistance. The principles are the same, so it's focusing on as healthful nutrition as we can, activity as we can, PCOS and insulin resistance is one of those health conditions that really can benefit from medical management, medication management, whether that's metformin, the GLP-1s. Sorry, we got a
Stroke alert activation, emergency room 4 now. Stroke alert activation, emergency room 4 now.
And sometimes hormonal management. So talking with someone who, a provider that is good with managing like hormone replacement or hormone therapy to kind of regulate cycles and things like that. So it is definitely a headwind, but it's not an insurmountable one.
And I guess I'll just add that sometimes with additional comorbid conditions, like sometimes it's thyroid disorders or PCOS, the tendency, especially online, is to really narrow the diet. And that can feel super restrictive and is probably not helpful overall in terms of weight management. So just recognizing that, again, the pillars are the same for someone experiencing thyroid disorder or PCOS. We just have to kind of adjust to your kind of personal situation. But yeah, give yourself some grace. Don't decrease your diet so much that you have no joy in the food that you're having.
So this person started exercising, kind of like one of your suggestions. They actually have gained weight. Any suggestions?
Yeah, so again, skill victories are part of it, but not the whole thing. If you're feeling strong, if you're preventing injury, we're winning. The other part of this, though, is, muscle mass is important. We want muscle mass. That can be part of weight changes, not the whole picture, certainly. But another thing to consider would be as we start exercising, our nutritional needs may change, and those hormones may also change, which drive a lot of, sometimes increased appetite. So making sure that we're being mindful of what we're using for energy in terms of exercise, and also what we need in terms of returning that energy with nutrition.
So the one thing I would add to that, which I think is, and I see this a fair amount, is that people will restrict their diet and then they'll exercise. And what I've found is that people's bodies are just then trying to really catch up from a massive deficit. So what I would generally recommend is when people are strength training or exercising in some other way, that they usually get some sort of healthful nutritional bolus right afterwards or right before, so that their body understands that it has gotten what it needs, and so it doesn't start searching for that later in the day. So I do find that that's what people do, is they'll exercise, they won't eat anything, and then they're ravenous for the rest of the day and they can't really catch up.
We're getting to the end of our time, so I think I'll be able to squeeze in a couple more questions here. So can you talk about fasting, the risk or the benefits?
Yeah, sure. So yeah, there's been a fair amount of studies around what I think people are, when they say fasting, I think what they're talking about is time-restricted eating. And for those who don't know what time-restricted eating is, it is limiting the amount of hours that they consume food in the day. So often you'll hear of like 6:18 or 8:24, or sorry, 8:16. And what that means is that they are eating only 8 hours and then fasting 16 hours, or they're only eating 6 hours and they're fasting 18 hours. And what the data shows is that it doesn't really matter. Or I shouldn't say it doesn't matter, but compared with a otherwise calorically restricted diet, calorie for calorie, it is no better or necessarily any worse. I will say that the experience that I have with my patients is that usually my patients will have skipped breakfast, and then they're catching up the rest of the day, and usually with non-nutritive, very hyper-palatable food. So I generally don't encourage it, but for some people, not our patients, it can work.
Okay. Can it be used initially to kickstart your metabolism?
I think short answer is no. In terms of metabolism, this is another kind of complex bodily function. But the best thing in terms of talking about metabolism is that resistance training and that exercise component of it. in terms of kickstarting weight loss, I try not to, I guess, encourage that kind of language though, because I think it can feel like a hill that you're, surmounting, and then it's just going to be great after that. And that's not necessarily what most people's weight loss journey looks like. It's hills and valleys, and sometimes really high highs and really low lows. And our goal is, let's start slow and maintain changes rather than starting really fast up this hill, and then possibly regaining later.
Last question, is Medicare an accepted insurance plan for your practices?
It is. Some Medicare plans, I guess, usually they cover visits with us. There are only a few diagnoses which they're covered for dietitian services. Usually that's chronic kidney disease and diabetes. But we are BCH employees, and BCH does take Medicare.
Thank you for y'all's time tonight. We have come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream.